So primary polycythemia, it's a red blood cell excess due to cancer of the erythropoietic line of the red bone marrow. Um, Polycythemia from all other causes is called secondary polycythemia. Um, those causes can include dehydration, emphysema, high altitude, physical conditioning, different things like that. The principal dangers of polycythemia are increased blood volume, increased blood pressure, increased viscosity. Blood volume, it can double in primary polycythemia because of the osmotic retention of water and causes the circulatory system to become tremendously engorged. Blood viscosity can rise up to 3 times the normal amount, and then circulation is really poor. Capillaries become congested with viscous blood, thick blood, and then the heart, it puts a lot of strain on that cardiac muscle, right? Chronic polycythemia can lead to embolism, stroke, or heart failure. The deadly consequences of emphysema and some other lung diseases are due in part to polycythemia. And then anemia, so too low rather than too high count of red blood cells. They can fall into 3 categories. So inadequate erythropoiesis or hemoglobin synthesis, hemorrhagic anemia from bleeding, and hemolytic anemia from red blood cell destruction. Nutritional anemia, it results from a dietary deficiency of any of the requirements for erythropoiesis discussed earlier. So its most common form is going to be iron deficiency anemia. So this is most characterized by small pale erythrocytes. Iron deficiency anemia is usually caused by blood loss without getting enough dietary iron to compensate for it. Elderly people sometimes develop pernicious anemia, an autoimmune disease in which antibodies destroy the stomach tissue. We also have hypoplastic anemia, so this is caused by a decline in erythropoiesis, whereas the complete failure or destruction of the myeloid tissue produces aplastic anemia, which is a complete cessation of erythropoiesis, so it just stops completely. Anemia has 3 potential consequences. So tissue hypoxia, which is oxygen deprivation, and necrosis. So the individual is going to be lethargic. They'll be short of breath upon physical exertion. Skin's going to be really pale because of the deficiency of hemoglobin. Severe anemic hypoxia can also cause life-threatening necrosis of the brain, the heart, and the kidney tissues. Blood osmolarity is reduced, so more fluid transfers from bloodstream to intercellular spaces, resulting in edema. And then blood viscosity is reduced, so because the blood puts up less resistance to flow, the heart's going to beat a lot faster than normal, and cardiac failure may ensue. So it's the opposite of blood being really thick, right? The blood pressure is going to drop because of the reduced volume and viscosity. Really common, well, not necessarily common, but one that you've heard a lot of is going to be sickle cell disease, so erythrocyte disorder. It's evolutionarily significant. It's a hereditary hemoglobin defect found mostly among the people in this list. It's a recessive allele that modifies the structure of hemoglobin. So a fun fact about sickle cell, so evolutionarily this was brought up because different diseases carried by mosquitoes, they affect healthy, round, red blood cells, normally shaped, but they will not touch sickle cell shaped blood cells, right? So on the one hand, evolutionarily, you're not going to catch that same disease from a mosquito that somebody with regularly shaped red blood cells is going to get. But on the other hand, the sickle cell shaped red blood cell can cause a lot of issues in terms of kidney or heart failure, stroke, joint pain, or paralysis. But those with only one sickle cell allele, heterozygotes, if you will, are still going to be resistant to malaria. So it's a pretty cool evolutionary thing that popped up just in terms of human evolution. Now we're going to move on to blood types. So here are our expected learning outcomes. We're going to talk about A, B, AB, O. We're going to talk about Rh factors and blood type incompatibility between mother and fetus when it comes to these different things. So blood types are based on interactions between antigens and antibodies. Antigens are complex molecules such as proteins, glycoproteins, glycolipids, and they are genetically unique to each individual except identical twins. So they occur on the surface of all cells and let the body distinguish its own cells from foreign matter. When the body detects an antigen of foreign origin, it activates an immune response. So this response consists partly of the plasma cells mentioned that we talked about earlier, secreting proteins called antibodies. So antibodies bind to antigens and mark them or the cells bearing them for destruction. One method of antibody action is agglutination, in which each antibody molecule binds to two or more foreign cells and sticks them together. So repetition of this process produces large clumps of cells that can cause the complications of the transfusion reaction that we're going to talk about here in a second. The red blood cell surface antigens that trigger agglutination are called agglutinogens, and the plasma antibodies that bind to them are called agglutinins. So we have blood type A, blood type B, blood type AB, and blood type O that all encompass the ABO blood group. So somebody's ABO blood group is determined by the hereditary presence or absence of antigens A and B on the red blood cells. So the antigens are glycolipids. They are membrane phospholipids with short carbohydrate chains bonded to them. Antibodies of the ABO group begin to appear in the plasma 2 to 8 months after birth. They reach their maximum concentration between 8 and 10 years of age, and then they slowly decline for the rest of one's life. They're made mostly in response to bacteria that inhabit the intestines, but they can cross-react with red blood cell antigens and are best known for their significance in transfusions. So a person's ABO blood type, it can be determined by placing one drop of blood in a pool of anti-A serum and another drop in a pool of anti-B serum. Blood type AB exhibits conspicuous agglutination in both anti-serums A and B. Type A or B agglutinates only in the corresponding anti-serum, and then type O doesn't agglutinate in either one. So blood type A person has antigen A, blood type B person has antigen B, blood type AB has both, often called the universal recipient, and then blood type O has neither, often called the universal donor. So this is what I was talking about. Anti-A binds to antigen A, anti-B binds to antigen B. Anytime that you put one drop of blood into a pool of either one of these serums, it can, and you look for agglutination, it can tell you what, it will tell you what blood type you're looking at. And this is a good visual of what I was saying in the previous slide. You see the agglutination. So in giving transfusions, it is super important that the donor's red blood cells do not agglutinate as they enter the recipient's bloodstream. So if type B blood were transfused into type A recipient, the recipient's and type B would immediately agglutinate the donor's red blood cells. So a mismatch causes something called a transfusion reaction, where the agglutinated red blood cells block small blood vessels, hemolyze, and then release their hemoglobin over the next few hours to days. These free hemoglobins can block the kidney tubules and cause death from acute renal failure within a week or so. So blood typing with blood transfusions is very, very, very important. And here's a visual of this. We won't talk about Charles Drew too much, but he is a blood banking pioneer. So he was one of the first to study transfusion and blood banking, and gave rise to, how we are able to do surgeries now and have blood on hand. So type AB blood is called the universal recipient because this blood lacks both anti-A and anti-B antibodies. So it will not agglutinate donor red blood cells of any of the ABO blood types, A or B or AB or O. However, this overlooks the fact that the donor's plasma can agglutinate the recipient's red blood cells if it contains anti-A, anti-B, or both. So for similar reasons, type O is called the universal donor. The plasma of a type O donor, however, can agglutinate the red blood cells of type A, type B, or AB recipient. So there are procedures for reducing the risk of a transfusion reaction in certain mismatches, such as giving packed red blood cells with a minimum of plasma. And usually, we call it, some different areas call it washed blood, right? So no blood plasma, just packed red blood cells. So the RH blood group, so this is named for the rhesus monkey, RHESUS, where the RH factor comes from. So in which the RH antigens were discovered in 1940. So this group includes the red blood cell antigens, of which the principal types are C, D, and E. Antigen D is by far the most reactive of these. So people who have the D antigen are considered RH positive, and those who lack the antigen are RH negative. So those who lack are recessive, those who are RH positive are genotype capital D, or which is homozygous dominant, or heterozygous for that. Whereas RH negative are lowercase d, so recessive. The RH type, it's often combined with the ABO type in a single expression, such as O positive for type O, for example. So that's type O blood with RH positive factor, or AB negative for type AB, that's RH negative. And these vary among different ethnic groups, just as ABO frequencies do. So anti-D antibodies are not normally present in the blood. They only form in RH negative individuals who are exposed to RH positive blood. So if an RH negative person receives an RH positive transfusion, that recipient is going to produce anti-D. So since anti-D doesn't appear immediately, it's not going to cause much of a problem in the first mismatch transfusion. But if that person would later receive another Rh positive transfusion, that anti-D could agglutinate the donor's red blood cells. Other blood groups, and then maternal fetal mismatches. So, hemolytic disease of the newborn, HDN, or erythroblastosis fetalis, it can occur when a woman has a baby that does not match her blood type, so with a mismatched blood type. Most famously, if she is Rh negative and carries an Rh positive fetus. The first pregnancy, like we just talked about, is not going to be very eventful because the placenta normally prevents maternal and fetal blood from mixing. But if there's a placental leakage during pregnancy or at the time of birth, or if a miscarriage occurs, then that mother is exposed to Rh positive fetal blood. And she'll then produce anti-D antibodies. So when she becomes pregnant again with the Rh positive fetus, those antibodies can pass through the placenta and agglutinate the fetal erythrocytes. And agglutinated red blood cells hemolyze, and the baby's born with hemolytic anemia, so HDN. If an Rh negative woman had one or more previous Rh positive pregnancies, her subsequent Rh positive children have about a 70% chance of being born with HDN. So such infants are often really anemic, and fetal hematopoietic tissue respond to the need for more red blood cells. Erythroblasts enter the circulation prematurely, and hence the name erythroblastosis fetalis. So in today's day and age, luckily, we're living in the 21st century. Rh immune globulin called RhoGAM is given to pregnant Rh negative women. So this will bind that fetal antigen so that the mother doesn't form the anti-D antibodies if exposed to the child's blood during birth, therefore can have multiple children without severe risk to the infant. And this is a visual representation of what we just discussed.